Definition of kind of MAC is the accumulation calcium along the annulus with a predominantly the posterior aspect and sometimes extending into posterior mitral leaflet, and then sometimes more involvement into anterior and increasing kind of severity, and then the complete circle of calcification and the dreaded circumstances to see when we do mitral surgery. And incidences vary from 5 to 42%, depends on the modality of investigation. And the age is kind of, as you get older, more calcification you tend to see in the high in the women and compared to men. And with the various modality, you can see with the kind of this, with transthoracic echo and transesophageal echo, and on the CT scan, and also the PET scan to see the kind of the severity of calcification. And why calcium accumulate in the area? And then obviously with when you look at the calcification activity with a risk factor, a contribution factor. So microcalcification can be detected in the CT PET scan, and look at this on this paper. You see effect on the calcification or activity by by the diabetes, high triglyceride, hemodynamic stress, and also with the kind of the microcalcification these by the mineral metabolism and inflammation and chronic kidney disease. So these are kind of multifactorial kind of all the condition that predisposing factor that lead to high kind of severe calcification area. What is the relevance? If patient doesn't have a mitral valve problem, patient doesn't need any other surgery, and calcification on its own, we don't think about it. But only when you're going to do the surgery, then when you see the calcified ring, then we start having the kind of chest pain for us, isn't it? So, and then it's certainly associated with increased cardiovascular adverse event and the increased cardiovascular mortality. And then its effect on the mitral valve dysfunction by sniffing, and then also they all come with the other kind of the disease processes. And so when you have a microannular calcification, your valve leaflets also very thicken and calcify, and then all the micro apparatus also calcify. So it's a very often quite difficult kind of scenario. And then what does a MAC contribute, increase the what kind of association, the kind of risk factor in the valves in mitral valve surgery? And so if you look at the mediastinal radiation, is probably one of the highest kind of increase odds ratio risk in the kind of the risk from mitral valve surgery. And then when you look down farther down, in the MAC is probably about odd ratio about 1.25 in the increased risk of mitral valve surgery. And then this is something that most of people have seen when you have a kind of severe calcification. This is not bad enough so that it can actually decalcify the annulus part of it, and then have a kind of the quite deep sutures to secure the annulus stitches to replace the valve. And then very often that's not the case. And then there are various surgical techniques that kind of people propose over the years and for the mitral valve surgery with a kind of severe calcification. And then many years we've done these decalcification of microannular calcification, especially posterior kind of annulus plane, remove the calcium and reconstruct the kind of microannulus with the pericardium, putting the surgical kind of the valve, and with a variable result, and quite a lot of patients end up with quite a lot kind of severe comorbidity, and then some patients have the annular rupture and then die from surgery. And then various proposal of folding the kind of atrial wall and bringing the kind of the mitral valve and kind of in suture line to above the annular plane level, and to reduce the risk of annular rupture. And then starting with a variety of other techniques. And then some people even try the kind of extra and anatomical bypass from bypass from left atrium to the left atrial ventricular apex, which is also kind of one of the way to approach it. And surgical strategy based on the kind of mitral repair, and then for if it is a moderate annular kind of the MAC, and then if it's severe MAC, then you just have to decalcify and have to replace it. And then there are two approaches you can think. One is about working around the kind of respecting the kind of the calcify annulus by working around the calcium, and to it's that advantage is a lower risk of aortic AV group disruption, and then subsequent demise. And then it is also possible to by leaving the calcium and using a transcatheter valve, and so that you don't need to disrupt cannot interfere with the kind of calcify annulus. And obviously it comes with the disadvantages, and then obviously replacement other than repair for these procedure. And then they have a higher kind of paravalvular leak, and they're less likely to heal, and that they're from paravalvular leak. And so suture around the calcium have the increased risk of the deeper the stitch you're trying to put, the more chance of damaging the kind of circumflex artery, and the less although kind of less common kind of conduction system kind of problem. And then there are a variety of kind of thing that you can see. But what about the decalcification annular kind of reconstruction? It allows a more of a natural prosthesis size and position for the mitral valve replacement, but it is likely to, it's also allowed to have kind of some repair process, so you can do the mitral repair by taking some of the calcium off. But they're technically challenging, and the longer bypass time, cross-clamp time, and then even though there's a relatively low, but it's quite kind of devastating kind of risk of AV groove rupture. So what about transcatheter mitral valve replacement? These patients with severe mitral calcification. And then see one of those study with the kind in 2017, 116 patients with a severe MAC underwent the transcatheter mitral valve replacement. And then with it is out of 29 patients die within 30 days, so mortality is still relatively high. And out of patients, the 106 patients, 1 year prior to the data kind of logged at the time, and then the 10 patients had the procedure beyond that mean follow-up of kind of the 5 months, and the 77 patients alive after 30 days. And then 1 year follow-up, and then there was 49 patients alive at 1 year. So 49 out of 106 patients who had the procedure. So actually kind of quite a lot of patients, the mortality is still kind of quite high with this procedure. And then if you look at survival, and survival cannot in the 360 cannot days is about 50%. So this is it is a kind of the condition that whichever way we were trying over a period of time, and not the greatest results. And then and starting kind of when you started doing more transcatheter approaches, people starting to realize in the importance of the aortic to this angle. And so that if the angle is the less and the more acute, the more chance of transcatheter valve being obstructing into LVOT. So you can start predicting which patient that you can actually predict can cause LVOT obstruction. And also you can actually predict, and by using the modality of the imaging to predict how the valve will sit and how much obstruction the LVOT will kind of cause. So which is also helpful to reduce the problem by predicting the kind of potential complication. So with the algorithm, we came up with the so if you have a mild to moderate surgical risk, and go for if you can leaflet repair is possible, and then the moderate MAC, and then go for conventional and the repair. And then if it's a severe MAC, and then go for repair after annular decalcification reconstruction. And then you can use either kind of techniques. If it's a kind of high risk, prohibited risk or surgical risk, and then you can consider upon near it is whether go for the medical therapy if his patient risk is too high, or you can go consider using transcatheter therapy. So let's go move on to the transcatheter about. So with that, the more kind of the people look into that, the more you have this the classification of the severity with diagnosis with a kind of echo and the CT, and then looking at the annular size, max score, and LV obstruction risk, and based on that, which the mitral kind of transcatheter valve will be suitable to choose. And also there are patients who are not suitable for transcatheter valve, and then the percutaneously, then you can start using the kind of transcatheter valve during the open surgical repair. And then this is the first one, the one from the Australia, Melbourne, and there you can see that using the kind of the severe calcified annulus, the mitral valve, and then put transcatheter valve in the open and the cross clamp, and then balloon expandable kind of the valve, and to replace that. And then also you can see if you're severe MAC but leaflet's reasonable and the suitable, then you can consider using MitraClip. And so by doing that, you can then have the benefit of repair, and as well as to kind of avoid that. And then other one is more people using lithotripsy everywhere, trying to start using the different kind of way of decalcifying or the reducing calcium, or the fracturing or the reducing stiffness. So one of the things is ultrasonic emulsification, and using this Skyler kind of system, and the open surgery where you can use it to aspirate and debride the localized calcium in the kind of annulus by reducing the stiffness, and then after that followed by implantation of the kind of normal prosthetic valve. And then and on top of that, if you require, you can do the same with the surgical implantation of transcatheter valve. And the additional one is a Tendyne, the transapical kind of the valve, and that's the one way of dealing with the kind of severe mitral annular classification. So most kind of thing will be there now, that kind of everywhere, even in aortic surgery, aortic stenting, that people are doing lithotripsy. You can do the same for mitral annular calcification, and then might reduce the stiffness, and then put the mitral kind of transcatheter mitral valve, and through that afterwards. And this is one of the kind of the case report from 81 years old patient who already have the TAVI valve in aortic position, and that with the lithotripsy assisted, and the mitral valve into the mitral position. So there are more the solutions are becoming kind of available, but at the same time, this is one of the kind of quite severe condition with plenty of potential complication and high risk of mortality. And so in conclusion, the mitral annular calcification associated with a high incidence of cardiovascular death, adverse event, and high mortality. And various surgical techniques and transcatheter approaches are now available. But you need to have a more creative approach to trying to treat these patients. And then further investigation required for understanding the condition, and then how to tailor the individual patient treatment in that approach. Thank you.